Muchas gracias. The presentation now is about the multidisciplinary approach to the treatment of rectal cancer. So I thought I would modify this presentation to be largely about advanced rectal cancer, because this is the area where almost all the disciplines involved in treatment of rectal cancer are involved. These obviously include the surgeon, and in many cases it may require a very experienced surgeon to help with the technical aspects of the surgical component of these multidisciplines. And of course we have the oncologist who can advise us on both the timing and the specific regimens to use in specific circumstances. The radiologist is important because they can help identify the location and extent of the local cancer, as well as where possible metastases may have occurred, and as well they will be able to advise us on the response of therapy by radiological means. The radiotherapists are critical as part of this team because, like the oncologist, they will help advise the surgeon as to the role of radiation therapy, when to use it, how much to use it, and when critical doses have already been used, what extra treatment can be added. Added to this is the role of the radiotherapist in the adjuvant treatment of intraoperative radiation therapy. The other elements of this, of course, are the technology associated with physiology and assessment of function in the case where restorative procedures are done, the enterostomal therapist when this involves an ostomy, and in general the medical expert in comorbidities like vascular, cardiac, and respiratory compromise. So I'm going to start by talking about the curative therapy for advanced rectal cancer. And I've defined it here as patients with T3 or T4 local cancers, and if there is associated nodal adenopathy, they will also be called advanced rectal cancers. I'll speak to the difference of total mesorectal excision versus site-specific excision, and of course en bloc resection, and the role of preoperative neoadjuvant therapy. Now, there are many factors which will impact on the curative surgery. The presence and location of distant metastases, and we've just heard a brilliant exposition on liver metastases. Whether or not for function after restoration, a colonic reservoir is advisable or not, and if so, whether this is best as a colonic J-pouch or a coloplasty technique. The technique of anastomosis will be briefly alluded to, and the post-operative management, which will be probably a continuation of the neoadjuvant therapy, its timing and amounts of treatment that are given, and then perhaps discussion on recurrent rectal cancer, which is one of the more difficult areas of our surgery. I will not dwell on the imaging techniques, except to say that being a multidisciplinary approach, we use some or all of the imaging techniques on the left side, from CT, MRI, ultrasound, even intraoperative therapy, angiography, and the PET-CT scan, And on the clinical side, we'll make these judgments based on digital rectal examination, mobility of the tumor, examination under anesthesia, and of course endoscopy with biopsy. Now, most of you, in fact I think all of you, are familiar with the grading system for staging and grading of tumors from the T1, T2 lesions, which are confined to the bowel wall, T3 and T4 related to presence or absence of penetrating of the tumor, and up to and including nodal metastases or establishment of association with adjacent structures. By definition, the rectal cancer can have local extension into the structures listed on this slide. Things like the cervix, uterus, vagina, to the prostate gland and vesicles, penetrating through to the anal sphincters, and of course the sacrum as well. In these cases of T3, T4, neoadjuvant chemoradiation therapy has become the standard of care, de rigueur, for the treatment of these conditions. Now, there still are some issues. For example, if the patient has a high-grade tumor but is a stage 1 or 2, does this merit chemoradiation therapy? The body of opinion these days is yes, that if these patients have a high-grade tumor, poor differentiation, then these patients will be subject to this treatment. And we then look at the level of complete response, which is both a clinical and radiological assessment, as well as endoscopic. And at what level of the rectal cancer do we consider that these therapies will be introduced? For many of us, it's been shown in multiple studies that an upper third rectal cancer behaves exactly the same way as a sigmoid colon cancer. And sigmoid colon cancers will not be subjected to radiation therapy, except in the rare circumstance where they fall down between the rectum and the pelvis and cause direct invasion, in which case radiation therapy will be used. But for most other cases, the patient will undergo treatment as if it was a sigmoid cancer. Different to stage 3, where nodal metastases are present, or worse, attachment or fixation to the side wall of the pelvis, where that will mandate having to do this. When one does the surgery, there is somewhat of a divided opinion as to the value of total mesorectal excision. That may seem strange because the standard of care for rectal cancer surgery is that of performance of total mesorectal excision, as has been popularized by Bill Heald, Rupert Turnbull, Mark Killingback, and several other experts in the field. But it's also been argued that you don't have to remove the entire rectum to do a curative operation and do a removal of all of the mesorectum. But this is somewhat argumentative because for a lesion in the upper third, we can only have to use site-specific, relating our margins of clearance to the level of the tumor. And with full mobilization of the rectum, we can usually leave a significant amount of the distal rectum, 5 to 7 or 8 centimeters, where the use of a pouch is really not necessary because function is identical whether or not one uses a pouch. Now, the other technique relates to lateral pelvic lymph nodes. This is a very difficult area. Lateral pelvic lymphadenectomy is a bloody procedure, and you want to be fairly sure of its value before embarking on adding that to the surgical technique. If one thinks that pelvic lateral lymph nodes are possibly involved, then one might take a biopsy or take a node out, submit that to histology, and if that's positive, that will call for a fairly advanced form of neoadjuvant therapy, of adjuvant therapy with chemotherapy and radiation therapy. And there are some patients with lateral pelvic lymph nodes where surgery can be done for extirpation of the tumor. Now, this is a cartoon of the amount of resection one will perform in the case of a patient with an upper third rectal cancer. You note the plane of excision is in the presacral space, total resection of the upper mesorectum, but still there is enough rectum left for an anastomosis to be made, whether or not radiation therapy has been given preoperatively. And of course, if the patient has ultrasound or MRI evidence of nodal involvement, preoperative radiation therapy would be given. So the appropriate site and location of the TME is in the plane behind the mesorectum in front of Waldeye's or presacral fascia. What is inappropriate is to use a technique in which the dissection is carried out too close to the tumor posteriorly, and in this case, which is mid-rectum, there is insufficient distal clearance and, more importantly, radial margins. So this summarizes the remarks I've just been making. TME, or total mesorectal excision, is appropriate for upper third, lower two-thirds will favor site-specific resection, and anything below that will be total mesorectal excision. Now, chemoradiation therapy, because we're talking about, excuse me, multidisciplinary approaches, the radiologist, radiotherapist, and the oncologist. And opinion has been divided over the years as to when to use either of these components. And where the current status of the art is that for any stage 3 cancer, this will be used. Any stage 3 cancer. By definition, this is radiological evidence of nodal involvement. Stage 2 is questionable, but if one has certain associated features, poor differentiation, evidence of vascular invasion on histology, then these will be given chemoradiation therapy as well. So we have to see with this if there is a complete response of the tumor, and then that may beg the question of the next level, next mode of therapy. So the tumor grading that is used relate to node positivity or not with T1 and T2 cancers, T3 and T4, the mobility or fixation of the tumor with tethering or fixation to the solid structures around it, cervix, vagina, uterus, bladder, prostate gland, and the sacrum itself. And of course, for lower third rectal cancers, the presence or involvement of the internal sphincter will be quite definitive with respect to whether or not a sphincter-saving operation, such as the intersphincteric proctectomy, as advocated by Rudolf Schiessel of Austria, is appropriate, or whether an abdominoperineal resection is required. Later on in the day, you'll be hearing more about that from some of the other speakers. If the tumor is high grade or the response has been incomplete with respect to the chemoradiation therapy, then further treatment will be required. I'm sorry, I've sort of advanced this the wrong way. So the inappropriate TME is where a close shave around the tumor is done, and the circumferential radial margin, CRM, is jeopardized or less than a certain amount. Most of us will try to go for a centimeter or more of radial margin to consider that complete. And when you have finished off the resection, be it, as in this case, an anterior resection, but an abdominoperineal resection will be precisely the same, you see this complete intact fascia of the mesorectum, which means that you haven't jeopardized the operation by cutting into the plane where lymph nodes are harbored. And so these are the sorts of specimens you'd like to get at the end of the operation. So can you still preserve autonomic nerves with total mesorectal excision? And the answer is yes, you can, but it requires careful dissection to identify those presacral nerves and to stay away from them. The posterior and lateral planes of dissection are between the visceral and pelvic parietes, but this can be done even sometimes with a nerve stimulator to identify that one is free of these autonomic nerves. Now, tumor can occur within the distal mesorectum in a certain percentage of cases, and here are several pieces of data ranging from HEALED to most recently HIDA of Japan, where distal spread of the primary tumor into the mesorectum was noted in sometimes as much as 24–25% of cases. And that tells us that in the surgical technique one uses, that one must take this factor into account in choosing a distal line of resection. As it happens, the circumferential radial margin is equally as important, if not more important, and this is considered when the techniques of establishing the value, the specific ability to be able to get beyond the tumor is judged with various types of dyes that are placed on the bowel before it's resected. Now, in this particular case, we've got evidence of extension through the bowel wall, but also notice the in your upper left-hand corner how close the tumor is to the margins of resection. We try to get 1 centimetre or more of clearance with circumferential radial margins. And the rate of recurrence of the cancer is directly related to the presence or absence of the tumor at the circumferential margin and the extent to which the clearance of this is done. Now, we would try to get at least 5 millimeters to a centimetre of clearance to be able to say that this is a good operation which is oncologically sound, but there are certain circumstances where that may not be possible. And if that's the case, then you have to add some further therapy. And that further therapy can be in the way of trying to control the local treatment by intraoperative radiation therapy if you have that facility available to you. The main expert in this area is Philip Quirk from Leeds, who published on this in the late 1980s in Lancet, and noted that with a standard resection, 27% of patients had positive margins circumferentially, 7% local recurrence, and if you were able to have, if you got a positive margin, that 29 to 78% had this, and with a negative radial margin, then 10% survival was possible. Anterior dissection is also important. Here, the surgeon is weighing in the balance how much anterior dissection one should do. The simple reason, and in the case of men, that here is where they live. This is where autonomic nerves, the nervi erugentes, run in this particular plane, and which are vulnerable to injury during the course of an anterior dissection of the rectum and the tumor off the base of the bladder, the prostate gland, and the seminal vesicles, and it's these patients who will also benefit from the neoadjuvant therapy. In the mesorectal plane, this is not quite so difficult, unless the tumor is invading the sacrum, in which case extraordinary measures, both in terms of adjuvant therapy and the degree of surgery, up to and including hemisacrectomy, may be required. So it's the anterior plane which is often the area where most recurrences will occur, because surgeons intuitively try to give a decent margin there to avoid autonomic nerve injury. Now, there are many different operations we can do for rectal cancer. Anterior resection, these are for curative operations. Extended Hartmann, colorectal anastomosis, you can see this as well as I do, and up to and including the pull-through operation. Mr. Moderator, you've got to wave your hand when I'm running out of time, please. Would you do that? Yeah. Thank you. Okay. 2 minutes? Okay. So here are the curative operations for rejoining the bowel together: the intersphincteric operation and coloanal anastomosis, abdominoperineal resection, about which I think Dr. Delaney will be talking about this later, local treatment, but for advanced rectal cancer, local treatment is only used for palliation. I could go on about the details of the operation, the surgical aspects of the operation when operating for cure, such as how to define what extent the vagina should be removed as a composite of the en bloc resection, and the prostate, which can be removed in part and still preserve urinary function with continuity reestablished. This is called a bladder-sparing prostatectomy, and while anterior sexual nerve dysfunction may occur, that's not the best and the worst of it. My time is running out, unfortunately, but I'll try to be putting this together in a formal presentation, which will be published in the proceedings of this particular meeting. And this will include the management of vaginal invasion and management of prostate invasion, bladder invasion, and how block dissections are carried out. Here is the plane of dissection for these operations in the case of a intersphincteric proctectomy, showing the dotted lines of where the resection lines are carried out and how to make the decision between intersphincteric resection, abdominoperineal resection, and that very difficult decision of pelvic exoneration. So when we see obstructive uropathy, when we see this occurring with bilateral effect, then this is going to call for extraordinary circumstances to try to get a complete resection with it, and with doing that, one will optimize the chances of cure. Thank you very much.